Okay, good day. My name is Brent Edwards. Today we're going to be looking at the shoulder. This is my lovely assistant helping us out today. So we'll begin. Initially, you want to start with assessing the cervical region, making sure that there's no radiculopathy giving you the shoulder issue. So we'll look at different cervical movements. So if I can have you look over to your left shoulder, look over to your right shoulder, good, back to neutral, look up towards the ceiling, look down towards your chest, good, neutral, left ear to left shoulder, so going to the side, and the other side, good. And obviously assessing the quality of the movement, making sure that things are the same on either side. You can also palpate the spinous processes, making sure that nothing stands out, as well as the soft tissue along those paraspinal regions. Again, you can also look at compressing the spinal structure to see if that gives any type of radicular patterns or injury patterns, clearing the neck. Okay. Next, we'll look at the anterior view, so assessing shoulder height, assessing the level of the acromioclavicular joint from both sides, assessing the pectoralis muscles, making sure they are both equal, assessing if one shoulder is slightly more higher than the other, assessing whether the shoulders are slightly more rounded, as well as palpating over the acromioclavicular joint, palpating the bicep tendon, palpating the pectoralis tendon. All could leave you with some indications of where the pathology is coming from. Right. Again, looking from a posterior view, if I can have you stand up and turn around, you can sit on this side. Okay. Posteriorly, same thing. You want to assess the level of the shoulders, you want to assess muscle bulk, going into the upper trapezius, looking into middle and lower trapezius and rhomboid, as well as the position of the scapula, making sure they equal on both sides, palpating the medial border of the scapula, palpating along the spine of the scapula, to palpate what is going on in those areas. Often what will happen around this posterior soft spot, palpation in that area can often give you anterior pain, indicating a slap lesion. Let's have you standing up and coming around to the front again. Okay. So from here you want to assess shoulder movement. So flexion, assessing any pain or provocation there, any discomfort, as well as adduction. So going into noticing any clunking or pain in that area. External and internal rotation, so from that position you can assess in there while stabilizing the scapula. That will give you a similar test to the NIRS test as well. So you want to be doing that actively and passively, so then you'll get the patient to slide both hands up above the head. Good, and back down. Good. Then out to the side, assessing. Good, and back down. Good. Can you get into that position? Good. Hands up and down as far as you can go. Good. And again, just assessing, you can relax, assessing equal movement on both left and right. Okay. So next you want to look at what happens in the back. So with this particular position, we're going to be looking at any scapular dyskinesis, maybe potentially a kinetic chain problem, causing level of injury within either of the shoulders. So we're going to get her to roll your shoulders forward, good, and roll them backward, good, roll them up towards your ears and down towards the ground, good. So you'll have it doing it in that position, and then you'll repeat it with her hands on the hips as well as with the arms straight forward. And you can relax. During this, you're just comparing the movements, any scapular winging or tilting, and comparing left and right. Okay, sulcus sign test. So depressing the humerus. Often, if there's ACJ dysfunction, you'll see that the clavicle then becomes more prominent, or if there's glenohumeral dysfunction, you'll see a sulcus sign develop as the glenohumeral head depresses out of the socket. For compression tests, you can do the crank test, and with this test, you're just moving the shoulder glenohumeral joint, trying to compress any structures in there and cause pain or provocation within the area. Jorgensen's test, so I'm going to have you put your arms next to your side and you're going to squeeze inwards. That's it, good, and then squeeze outwards, good, and that's just indicating any issues within the bicep tendon. Speeds test is the next test. So with your arms straight, good. You're going to lift up towards the ceiling. So lift, lift, lift. Keep your arms straight as you lift. That's it. Lift, 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 lift. Good. And you offer resistance. Any pain over the bicep tendon area will be indicated if there is a bicep tendinopathy. Okay. For slap lesion assessment, we're going to be using Kuhn's test, which is a combination of 3 different tests. So we're going to be using adduction with inferior distraction. So placing pressure into there. As mentioned before, that inferior sulcus test, as well as the Jorgensen's test. So from this position, I'm going to have you rotate that way. Okay, off you go. So turn, 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 turn. Good. And if there's any pain over the bicep tendon. So if 2 of these 3 tests are positive, it's highly probable that there is a injury in the slap lesion area. Okay. O'Brien's test is another test that can be used. So we're going to put the patient thumb facing down with adduction and flexion. Okay, you resist me as I try and push you down, so hold it there. Hold, hold, hold. Good. If pain is felt in this position and you change the position and you resist here, hold, hold, hold. Good. And that relieves the pain or feels less painful, that's also an indication of a positive test for slap lesions. Okay, then we're moving to dynamic labral shear tests. This will try and position the arm in a throwing position, so a lot of baseball, cricket, overhead throwing movements. Here, you're starting at 90 degrees and you're moving up to 150 degrees, and you're putting so my right hand is applying a posterior-anterior force on the glenohumeral joint, with my left hand getting into different degrees of shoulder flexion. Any function, any pain, any clicking, any apprehension will be a positive sign. Okay. For the biceps provocation tests, with the athlete abduction and external rotation. So we're going to have the hand pronated, and from this position, if she feels any pain over the anterior shoulder, that would be positive. At the same time, you can pull your hand towards your head. Good. Any pain in that position will also be positive for a slap lesion. Job's relocation test. Can I have you lay on your back on the bed? Okay, you'll have the patient come all the way to the edge of the bed. Okay, so the shoulder is stabilized, the glenohumeral joint is free to move. Externally rotate. If the patient feels any pain, you apply an anterior posterior force to relocate the joint, and if that reduces any pain, then that is a positive test. So you're sitting up. Okay, rotator cuff impingement. So we're going to get the elbow flexed at 90 degrees. And so push outwards. Good. For those, we're looking at infraspinatus as well as the teres minor. For the opposite, okay, pushing inward, we're looking at subscapularis as well as the pecs. To eliminate pecs and get pure subscapularis, you can adduct the elbow slightly and have it push inward. Good. That'll give you more pure subscapularis. Empty can test will be the next one. So now you pretend like you're throwing away some water, slightly more outward. Good. Hold there, nice and strong. Hold. Good. And that's going to indicate supraspinatus impingement. Okay. So as you saw before, the NEARS test, we stabilize the shoulder blade, try and cause some impingement within the shoulder, within the glenohumeral joint, as well as Hawkins test. I prefer to do it this way. The patient is nice and relaxed, and you can cause some impingement or try and provoke any form of impingement within the shoulder in that position. For general laxity, obviously in a patient who is pregnant, generally they are a bit more lax due to hormones, but for a general athlete, you can flex the fingers backwards. To assess the laxity, you can take the thumb and try and get it to touch the forearm, as well as looking at the position of the elbow when in full extension. For the shoulder, you can use the apprehension test. So standing behind the client, you can, if they are apprehensive or feel any pain or discomfort, that is a positive sign for laxity within the glenohumeral joint, as well as using the sulcus sign described before. All right, that's our assessment. Thank you very much.